Afternoon, good evening to all of our webinar joiners from around the country and around the world. Today, you are joining the webinar, a fireside chat. We'll be doing a brief Ebola virus disease update, and then we'll get into our 2026 World Cup HCID Preparedness. As this is a bit informal, we hope that you as the audience will engage with our panelists today and ask questions throughout the webinar. Today, our webinar is being hosted by NETEC, the National Emerging Special Pathogens Training and Education Center. The mission of NETEC is to set the gold standard for special pathogen preparedness and response across health systems in the U.S., with the goal of driving best practice, closing knowledge gaps, and developing innovative resources. NETEC has 13 Level 1 regional emerging special pathogens treatment centers that are throughout the country in the various HHS regions. Please use this map to familiarize yourself with your nearest regional emerging special pathogens treatment center for your region. NETEC has several areas of focus with a consultation and assessment, which is basically allowing hospitals to gauge their readiness using self-assessments and then ask for help from our technical experts. We have an education and training arm, which includes things like this webinar, as well as in-person and virtual courses and educational content on our website. We also have a research network and then international partnerships. So welcome to our webinar. We're so excited to have all of you with us today. My name is Anna Yaffe. I'm an emergency physician at Emory University and a co-lead of the adult care work group for NETEC. Today, I'll be serving as a moderator to help facilitate the conversation with these experts. I'm so excited to be sitting today in the virtual fireplace with our experts. I have with me Dr. Ryan Maves. He is a professor of medicine and anesthesiology at Wake Forest University School of Medicine, where he serves as chief of the section of critical care medicine and as an attending physician on the transplant infectious diseases service. I also have Dr. Jeffrey Dichter, a professor of medicine at the University of Minnesota with a professional focus on disaster preparedness and response. He also serves as faculty for the University of Minnesota's High Consequence Infectious Diseases Special Pathogens Unit. And finally, I'm with Dr. Alex Isakov, who's the founding executive director of the Office of Critical Event Preparedness and Response, CPAR, and the director of Emory's section of Pre-Hospital and Disaster Medicine, where he leads Emory EMS. Dr. Isakov also serves as a co-lead for NETEC's EMS working group. We also are going to be sharing information, which I will present today, by Dr. Gavin Harris, who is unfortunately unable to join us, but has sent a situation update for our Ebola virus disease outbreak, as well as Andy's Hantavirus. He's an assistant professor of medicine at Emory University and medical director of the Emory University Serious Communicable Diseases Program, Project ECHO. So with that, we will jump into the SitRep and then move into our conversation. So we'll be speaking today on an update of the Ebola outbreak in Democratic Republic of Congo and Uganda. I'm sure that most of you on this call are aware of the outbreak that's ongoing and unfortunately escalating in the region. This outbreak was declared a public health emergency of international concern by the WHO on May 16th. And as of the last SitRep on May 25th, there's a total of over 900 suspect cases, 105 confirmed cases, 223 suspected deaths, and 10 confirmed deaths in 3 provinces across the Democratic Republic of Congo. This outbreak is in the northeastern border region of the country, which is a historically challenging area to access. So this is why some of these numbers are still fluid and we're getting more and more data each day. Additionally, there have been some cross-border transmission with 7 confirmed cases and 1 confirmed death in Uganda. So far, there have been 5 Ebola treatment units stood up by international responding agencies. Going into a little bit of background of this outbreak, the index case is suspected to have died on April 24th. And initially, there was several samples, 20 samples tested that were using the standard Ebola expert, which is targeting Ebola Zaire. And those samples were negative for Ebola Zaire virus. The samples were then sent to the reference laboratory in the capital city for further analysis. And 10 of those samples were analyzed and confirmed as Ebola virus by PCR, and then genomic sequenced to be Bundibugyo virus. And so this virus was not initially targeted by the initial panel, Ebola expert panel. So that's why the identification took a little bit longer for this particular outbreak. Community spread then occurred for several weeks prior to detection, potentially due to travel, and then also open casket funeral practices. There's still a lot that's not known about this outbreak, and I think every day more and more responders are coming online and kind of trying to figure out some of the details. And so every day, I hope that we will have more information as we prepare in response to this outbreak. Ebola is not the only thing that's happening in the world right now. We did want to also provide an update on Andy's hantavirus. As of May 26th, there have been 13 cases, 11 confirmed and 2 probable. There was recently one new case identified in British Columbia from a traveler who returned from the cruise and confirmed at the National Microbiology Lab in Winnipeg. And then also one new case has been recently identified in Spain who was a high-risk contact of a cruise ship passenger. As of today, there are no positive patients in the United States, but we are continuing monitoring until the end of the incubation period from the last exposure, which for most of the persons under quarantine is still for several further weeks. There are currently 41 passengers being monitored throughout the United States. I think it's important to just consider the outbreaks that are currently going on in the world as we have this conversation about World Cup preparedness for HCID. It helps couch our preparedness efforts, and it helps us kind of understand what potential threats could be. So without further ado, I'd like to welcome my panelists onto your camera if you feel comfortable, and we can begin our conversation. For all of you who are attending, I do want to call your attention to the locations of the World Cup games that will be played in the United States. So by our HHS region, you can see that we have World Cup sites all throughout the United States. And you can, again, find your region and find where your nearest World Cup site is. It's important to just think about this as you think about your locations of your own facilities, as well as your nearest regional emerging special pathogen treatment center. So without further ado, I'd like to get into some of our questions. Again, thank you so much for proposing questions that you have thought of ahead of time when you registered for this webinar. But also, again, remember, please feel free to use the Q&A box for direct questions for our panelists. So I'd like to start off the conversation just thinking about what it is that we are even concerned about as in advance of the World Cup. So my first question is to Dr. Isakov, and I'd like to know what, if anything, are travelers to the U.S. being screened for in advance of the World Cup?
Hey, Anna, thanks for the question. Well, I think we all know, just reading in the media, that because of the Ebola outbreak in DRC and adjacent countries, that the travelers that have been in those countries in the last 21 days are having their travel funneled to certain U.S. airports for screening. And the numbers of airports that are included is increasing. I think it started with just Dulles in the D.C. area, and then Atlanta. I saw JFK added to the list, and I think Houston as well. So in terms of formal U.S. government screening, anyone with travel to an Ebola-affected country is getting screened. Some assessment of whether or not there are high or low risk contacts, and then follow-on monitoring under the guidance of the state health department where they're going, if that's indicated. Beyond that, there's no formal screening process, writ large, for people that are coming to partake in World Cup. I think we'd probably get into this later, but local jurisdictions, state health departments, of course, NETEC and the NSPS have always been big advocates for identify, isolate, and inform to increase awareness among frontline clinicians about infectious diseases and communicable diseases that they might be more aware of because of a large number of international travelers. And that might include screening for recent travel to the DRC, South Sudan, Uganda, and the appropriate signs and symptoms within that 21-day incubation period. I'm sure people will be have increased awareness about Andes hantavirus among travelers that come from Argentina or Chile, even though it should be clear that not every place you travel in Argentina and Chile would put you at risk for contact with the Andes hantavirus, but I'm sure there'll be some increased vigilance for people with fever, myalgias, constitutional signs and symptoms, and recent travel to those countries. And I guess the last thing I'll say about that, because I know you have other questions, is that where someone's traveled, what contact they may have had, either in regions of a country that would put you at risk for exposure to, rat droppings, or in a country where you might be exposed to somebody ill with a high consequence infectious disease. I don't think the expectation is that every frontline clinician is going to be able to sort that out completely, but know enough about the incubation period, the travel history, to then, call for some further guidance and interview maybe by a trained ID epidemiologist. Most state health departments have resource phone numbers that any frontline clinician could call to get help with identifying, or determining the risk that someone actually harbors a high consequence infectious disease.
Thank you, Dr. Isakov. Dr. Maves, I wonder if you can share what pathogens you might be worried about kind of in the next coming months.
Yeah, it's a great question. And thank you, Dr. Yaffe. Obviously you can't open a newspaper or click open a web browser without hearing about viral hemorrhagic fevers, about the current Ebola outbreak that's already being discussed, and the Andes hantavirus. That being said, those are dramatic, somewhat localized, and with the kind of standing things that Dr. Isakov described with airport screening and the like, are not terribly likely to have a major impact on things like the World Cup. Honestly, the one that gets my attention is measles, where we have concerns for an under-vaccinated population, both coming from abroad and now locally. A problem that if you'd asked me 10 years ago, I didn't think we would have to exert a lot of psychic energy on. But in terms of the raw contagiousness of things like measles, it's very easy to see how a large-scale outbreak could occur. Another one would be varicella. Again, with a fair number of people, certainly people at risk, will have had either vaccination, prior childhood infection, or a combination of the two. But varicella spreads very rapidly in enclosed spaces. And the mortality of varicella and the morbidity of varicella goes dramatically up starting around age 18, 19. A disease that is, generally unpleasant but relatively mild in children becomes a potentially serious pathogen in adults. Somewhat lower propensity for spread, very much lower R naught, but still on the list of things to worry about. Would be things like meningococcal disease. Certainly, now I will say that area of concern overlaps somewhat with the Ebola area of concern and the so-called meningitis belt across Central Africa. But there is certainly endemic meningococcal disease out there, and the incubation period makes it plausible that there could be small outbreaks in that setting. Not terribly likely, and it seems like you'd think, well, I mean, people aren't going to get on a plane with bacterial meningitis, but actually, if you look at the Hajj, one of the global annual global events comparable in scope to the World Cup, the Saudi government requires proof of meningococcal vaccination before coming to the Hajj, not because of high levels of endemic meningococcal disease there, but rather because a large proportion of the Muslim world lives in meningococcal endemic areas. And so those would be kind of the big ones, right? And certainly influenza, respiratory viruses, and the like. But when I think of things that are relatively common, relatively ubiquitous, and have the potential to spread in closed spaces. Measles, varicella, and meninge rank higher on my personal list than Ebola and Hantavirus, although Ebola and Hantaviruses are, of course, near and dear to my heart. When we talk about screening people who come from Hantavirus endemic countries, well, we all live in a Hantavirus endemic country. Sinombe virus is in the Four Corners area. So it's, worth considering. Thanks.
Absolutely. I think that brings up a really important point that these special HCIDs or special pathogens are low likelihood, high consequence diseases, but all these usual players, measles, influenza, malaria, right? For a return traveler, things like that are things much more likely for a frontline physician or provider to encounter. Maybe we can go quickly back to Dr. Isakov. Crystal in the chat did ask a question about what we mean when we say screening. We talked about screening at the airports. Is this a laboratory screening, or what type of screening might be conducted either at a frontline facility or even at a point of entry?
Thanks. It's not lab screening. It's all screening of travelers for signs and symptoms of illness and known travel to an affected country. So in this case, countries affected by the Ebola outbreak in the DRC, South Sudan, Uganda, and when we talk about screening, upon arrival at one of the airports conducted by federal authorities, it will be, the federal authorities will know that you've been a traveler from an affected country, and they will assess whether or not you have any signs and symptoms. They may assess the risk of your having had close contact with somebody infected with Ebola virus disease because you recently went to a funeral in the last 21 days of somebody suspected to have died of Ebola, or you were in an Ebola treatment facility or another healthcare facility. But they may risk stratify you as a high risk contact versus low risk contact, and then make follow-on recommendations about how you should be monitored for the duration of that incubation period. If you're a low-risk contact, I suspect that the monitoring that's recommended is self-monitoring, being self-aware about signs and symptoms, taking your temperature, and then if you do develop signs and symptoms of illness, knowing who to call. First, isolate yourself from contact with others so you can avoid transmission if in fact you have the disease or concern, and then calling the health department to let them know you developed signs and symptoms so you can get the follow-on assessment, which may very well include testing if you have concerning signs and symptoms. High-risk contacts who remain asymptomatic may actually have more active monitoring by state health department to ensure that they're not developing signs and symptoms during that course of an incubation period. I think for frontline healthcare personnel, who are just encountering patients either in the EMS system or at urgent care or emergency departments, as we're all champions for identify, isolate, and inform. And the question might be, have you traveled outside the United States for 21 days, for 30 days, some number of days that encompasses the incubation period, let's say for Ebola virus disease. And if you have you traveled to the countries of concern? And do you have any signs and symptoms of illness today? And while I know there are a number of electronic health records that are in play at frontline healthcare facilities, I know that Epic has, added the screening for Ebola virus disease now as part of the triage process.
Great. Thank you so much. Dr. Dichter, I wonder if we can talk a little bit about how you'd recommend healthcare facilities prepare to take care of a patient or multiple patients suspected of having one of these high consequence pathogens.
Well, thank you, Anna. Again, just to highlight my colleagues' concerns, probably the best way is to be mindful of international travelers. And the only caveat I would add is, although many of those will be from other countries coming to visit during the World Cup, many of them are Americans who've been abroad who are coming home as well. So just to be mindful of both populations of patients. To try and really get a good, as Dr. Isakov has indicated, a good travel history, to be able to recognize that you may be indeed dealing with a special pathogen, or whether they're family members or friends that may have infected this person. And your resources are really your infectious disease or your infection control within whatever organization you work for, presumably an emergency room. Local departments of health are, in my experience, are usually very up to speed with this. And NETEC as a resource as well. So just to be able to recognize it and then to isolate it, be certain that you have isolation rooms for them, to be able to have your personal protective equipment, your PPE available. And oftentimes that may be just, contact precautions. It may be droplet precautions as well with an N95 and a face shield. And if it's really something that you're seriously concerned about, such as Ebola, high consequence disease, to be able to have a higher level of isolation as well. The most important thing is to isolate them, keep them isolated, for instance, in an emergency room until you're able to assess and know what you're dealing with. And then your friends, you have to call upon your friends, your fellow institutions, your departments of health to try and figure out what it is they need and where they need to be transported to, if indeed they need to be transported. So really most hospitals will have some availability in the emergency room ICUs for, isolation, possibly respiratory isolation, but whatever it is, to keep them available, to make sure your staff are all in appropriate PPE. And the last comment I would make is to be sure that you have a way of disposing of your PPE when you're done with it, or cleaning your PPE when you're done with it. Often something that we're not used to, but if you're dealing with a high consequence illness such as Ebola, hopefully we won't see that. But if you are, that changes how waste is disposed of. So just to be mindful of those things. And the last comment is really reach out to your allies, healthcare coalitions, especially your departments of health. They should be able to help you in your infection control within your own organization.
Thank you so much for that. I think one of the questions that we got actually a lot in the registration process and in the Q&A right now is how to be creative with a space in the emergency department in order to kind of isolate and appropriately take care of a person under investigation. Do you have any recommendations for facilities as they're thinking about preparedness and their preparedness plans, how to think about their physical space in the emergency department?
That's a more difficult one. Emergency rooms often have specific places, whether it's a biologic or some kind of chemical or other kind of events that can happen. They will usually have some space available that's sequestered away from the main areas where they're providing care. If you're lucky enough to have that, I would utilize that space to your best advantage. It's always a little worrisome to transport a patient once you've identified them as potentially having a high consequence disease. But if you do need space, then whether it's an ICU level care or someplace where you can provide the care that you're going to need to provide, that's isolated away from other patients at the same time. I don't know that there's an easy answer to that, but that certainly thinking about not just infectious but biologic, other places that you can sequester patients where you can provide the care and keep them away from the rest of the population that you also have to be providing care for.
Thank you so much. Dr. Isakov, I don't know if you can comment a little bit about how to don and doff in places that don't have a traditional anteroom in the emergency department.
Yeah, sure. I provided an answer in the text, and happy to answer follow-up questions. I mean, clearly having an anteroom for donning and doffing of PPE is ideal. I think we all recognize that many emergency departments don't have the luxury of an anteroom, but what's clear is that if you have a patient that needs to be isolated, and I think the way the question was asked, in an airborne isolation room without an anteroom, what would you do? Well, we know that for donning and doffing, especially when concern about an HCID exists, you want to have that donning and doffing procedure observed by somebody who's trained in the donning and doffing of that PPE ensemble and can provide some assurance that good infection prevention practice is being implemented. So that's going to take some space because you need room not just to don and doff the PPE of the clinician that'll make patient contact, but you have to have enough room for that trained observer to participate too. Now, it may be based on the configuration or the footprint of the emergency department that donning and doffing is happening in an adjacent room that's reserved for that purpose. So in other words, if the emergency department's procedures are that after making patient contact, it's there's concern about an HCID, many emergency departments then identify the room where they would quickly, move that patient to isolate them. And it may be that the emergency department procedure then also makes the adjacent room available to serve as an anteroom for that donning and doffing purpose. If you don't have that luxury, then you're stuck trying to make space for that, in the emergency department hallway, which you may tape off, as a matter of convention to afford enough space. And, having enough space to do this properly is important, to really minimize the risk of an inadvertent exposure to potentially infectious bodily fluids. So a lot of it just depends on the physical space in the ED.
Yeah, absolutely. It is super challenging in the emergency department environment. We feel for you as practitioners ourselves, but also I think we can really be empowered to be creative as we are in our day job every moment to think creatively and be safe in taking care of these patients. I did want to move, and I'm loving this conversation in the webinar chat. Again, I just like to remind everybody, if you have a specific question for our panelists, please put it into the Q&A at the bottom of the webinar screen so we can get that answered. In the meantime, I'd really like to move towards thinking about kind of like larger scale events. In advance of the World Cup, a lot of our facilities are preparing for mass casualty incidents. And I think that biologic mass casualty incidents or screening for biologic threats during a mass casualty incident is important. So Dr. Maves, I wonder if you can talk a little bit about how facilities can prepare for potential surge from a biologic MCI.
Well, I mean, no joking intended. It wasn't that long ago that we had one, right? And I'm hopeful that although I think a lot of our society and a lot of us would like to put the pandemic behind us, nonetheless, I think we actually, we learned some skills there that can be very valuable. I do have this kind of hypothesis that the first case is going to always catch us with our pants down. Right, that the first person with the first adult varicella, the first hantavirus, the first what have you, will probably come as a surprise despite, all the adequate preparation. I think from a practical standpoint, one of the things from the pandemic that I hope is a lesson we learned is adequate supplies of PPE on short notice. Right. I think there's been a lot of ways that health systems do their supplies with, just-in-time purchasing, limited stockpiles for emergencies and the like. I worry that may be one area of weakness in the event of a biological MCI, and ensuring that we have at least some reasonable number of days of equipment on hand for a reasonable number of patients, right? And that would include, just like Dr. Dichter was saying, gear for patients who require negative pressure isolation. And I would say we should have a bias towards, in any new, as yet uncharacterized outbreak, to assume high risk of transmission and assume the need for negative pressure N95s, PAPRs, and the like, until we know better. Right. So ensuring adequate material for contact precautions, be it impermeable gowns, adequate numbers of gloves and the like, and then some manner of face protection, be those, again, goggles, disposable equipment, and so forth. One thing that I do think about is shifting our dependence on single-use disposable items at a health system level and looking more at durable PPE, so elastomeric N95s and the like, as things that are not as susceptible to surges in demand. Now, in the case of viral hemorrhagic fevers, I appreciate that leads to its own challenges because of the waste disposal nature of it and the difficulty in cleaning some of these devices. And, and I certainly understand that a reusable contact precaution gown is not necessarily something we would want to pursue in the case of a VHF patient. But in other populations and other somewhat, shall we say, more probable outbreak events during the World Cup in the United States, I think having that kind of preparation would be appropriate. And then as we've talked about before, practice. These are, as you beautifully put it, high consequence, low frequency events. And there is no other way to prepare for those other than to drill, than to practice. In fact, just right before our call started, our health system with I'm at Wake Forest in Winston-Salem, North Carolina, our sister facility down the road in Charlotte. We are starting our organizational plans for how we will plan where we would put PUIs, how we would transport those patients and so forth, because, you regret that it seems to be these outbreaks are what provoke these planning decisions, but, never let a crisis go to waste. So regular drilling and regular practicing, Dr. Isakov and Dr. Dichter both mentioned donning and doffing, and certainly for VHF, that is probably the highest risk thing. I mean, most of the care of these patients is just medical care, right? It is largely supportive care. Maybe in a few isolated cases, there is some manner of specific chemotherapy for it. The challenge is not the cognitive work of medical care so much as it is the precautions we have to take to protect ourselves, our staff, our colleagues, our friends.
I love that you brought up the idea of drilling. I think that's a great way to learn from learn in a steady state. Do you have any recommendations for facilities who haven't really thought about drilling yet?
Yeah.
Like, to go to do that?
Yeah, well, I mean, so there is an organization I learned of called NETEC that has a certain degree of resources that these places can refer to, and I think that honestly, when I have to start setting up these plans, the NETEC website and the NETEC repository is one of the first places I go to when I'm talking to my own facility and then to my own colleagues. Unlike you, I do not work at a biocontainment unit. Our nearest one is down the road from us in Chapel Hill at the University of North Carolina, run by a friend of many of ours, Billy Fisher. So that is one. There are actually a number of published scenarios out there that can be accessed online in simulation scenarios that people can use for managing for kind of putting people through the paces of how to drill. Actually, a number of us wrote some of these during the 2014-2015 outbreak, and those are available in PubMed. Just Ebola simulation. And that can be a useful way to put people into a more, shall we say, naturalistic environment for drilling. Obviously, just donning and doffing with practiced and experienced people is going to be one of the most important aspects to any kind of drilling. One thing I do think about in drills a little bit is kind of a secret shopper concept. Like, would it make sense to let people know you're going to do it, but at some point, maybe slip a simulated patient into an ICU, a ward, an emergency department, and see if the historical factors get picked up in screening. I don't know a way to do that would flow naturally with the normal flow of a busy emergency department. But that might be an interesting way to see if travel screening is actually happening in the way that we are hoping so that we can identify these people earlier. I think we did a pretty good job of that at different times in the pandemic. But that would be, I think, a twist on the drill that might be interesting, not just the mechanical act of donning and doffing, but also the cognitive act of appropriately screening and appropriately detecting, because I think that's probably our big weak spot, right? I mean, how many cases of, malaria does one see where there is no, a febrile patient comes back and no one has asked them, where have you been? What did you do? Right.
Absolutely. Absolutely. Dr. Dichter, I wonder if you can talk a little bit about kind of like escalation in a surge setting. Is there a consideration for cohorting of patients? When do we think about crisis standards of care? Things like that.
There isn't any specific threshold, but the important thing is to recognize that something's happening. And typically, you're going to see a number of patients. If you're seeing a number of patients coming in, you're obviously having an escalating potential of an epidemic. And then it's going to really be important as to, what infection, what the consequence of that infection is that you're dealing with, how much level of PPE, how much isolation there is. And again, there's no substitution for recognizing what's happening. And the other thing that's really important is communication, both within your organization, especially if you're a big organization. specifically looking for the resources you have, both in terms of space to care for people that's appropriate, your level of PPV, as Dr. Maves has alluded to, as well as the number of staff, which is usually more the rate limiting or the more limiting resource than those other things. And it's also important to involve your region, whether it's a healthcare coalition, your Department of Health. You have to alert those around you so you can both work with them, depend upon them, and start to think on a regional or a state level of how you're going to provide for care of a lot of patients that are beginning to evolve. And the last comment I'll make is during the pandemic, as Dr. Maves has noted, we learned a lot about providing a lot of care for a lot of sick patients. But probably one of the things I think we learned as we look at data, as we get further from it, is that transferring patients earlier may be one of the most effective ways of providing best care rather than trying to, if you will, tough it out as a hospital or as a health system by managing the care, but moving the patients to other places that are appropriate to provide care provides better care for everybody, both those being moved and those, benefiting from the resources at the institution.
Absolutely. I think that all of these are really important points. And what we know from some of the prior outbreaks is that patients that get aggressive supportive care, including aggressive critical care, actually can do really well. And so getting a patient to a facility that can provide safe, effective, aggressive supportive care can be the difference in that patient's outcome. So I think that's
absolutely, Anna. Thank you for pointing that out.
I wonder, Dr. Isakov, if you could talk a little bit about the conversations maybe facilities need to be having with services such as the lab, such as security, environmental services, and public health partners when they're thinking about making a preparedness plan.
Sure. If we're talking about high consequence infectious diseases, I think we all know this is a multidisciplinary effort, really like any preparedness activity is. And so, Anna, just alluding to what we described before, if you're trying to increase sensitivity for identifying somebody who might have a high consequence infectious disease, a communicable disease, you'll have a screening process in place. So somebody, maybe even the clerk that's helping you register, is facilitating those questions about recent travel and signs and symptoms of illness. Then clearly the staff in the emergency department need to know how are they going to isolate that individual to prevent exposure to potentially infectious bodily fluids, for other patients, for other clinical staff, non-clinical staff. So that requires some coordination, obviously, with nursing leadership and perhaps with facilities leadership, even to organize the response for a facilitated anteroom for donning and doffing of PPE. Any management of that patient, obviously, again, requires that nurses, techs, physicians, APPs, are trained in the donning and doffing of PPE for making patient contact. There clearly has to be some procedures with the lab about what clinical tests might be done safely if somebody is suspecting a high consequence infectious disease, right? Which is different than diagnostics. But if you have somebody that's presenting ill, even if you're concerned about a high consequence infectious disease, I think this has been mentioned before, you're more likely to have a more common disease like malaria, for example, which also requires, timely response, and in many cases requires some resuscitative intervention. And so, having an ability to provide clinical care for a patient, even while you're waiting for, the approach to diagnostics is important. Security is clearly important to secure pathways for patients, and we also need to work with our social services, maybe even spiritual health group to assist with families that might be accompanying those patients who are coming, for assistance. Interpreter services are always valuable in frontline healthcare and will be maybe in this case as well. And depending on what the concern is regarding the clinical presentation, travel history, then your involvement of environmental health and safety is critically important for proper waste management and cleaning and disinfection of affected areas that the patients had contact with. I think that's I think you'd mentioned the importance of involving, and we've mentioned this more than once, the importance of involving the local and often state public health authorities for assistance. This is part of the identify, isolate, and inform paradigm in ensuring public health is tuned in to either help you with risk stratification, or if you're pretty comfortable about the concern about contact and the presence of an HCID, then working with the health department for sample collection, diagnostic testing, any case investigation, follow-up contact tracing that might be required is all very important. So, closing out with what I said in the beginning, multidisciplinary approach to this is critical.
And Dr. Isakov, we forgot one of your favorite disciplines, which is EMS.
I'm so glad that you mentioned that. I'd be embarrassed if we didn't talk a bit about EMS. Of course, we're communicating with the EMS community all the time. Also, underscoring the importance of identify, isolate, and inform, for their own safety, right? Identifying somebody that might have a high consequence infectious disease because of signs and symptoms, because of travel history, because of close contact with somebody else who's suspected of having that illness, is important for the EMS community to implement the appropriate hierarchy of controls, don the appropriate PPE ensemble to protect them from potentially infectious bodily fluids. But also critical, I'm a big champion of the interface between EMS and the hospital to improve patient outcomes. But in this case, not only is there a chance it will improve patient outcomes, but it'll improve the safety of the clinicians caring for the patients. If EMS suspects an HCID, they need to alert the receiving facility that they suspect it, so that the team can be ready to, manage the patient properly, isolate them properly, and the clinical team, be in the appropriate PPE ensemble to keep everyone safe.
Thank you so much for that. Kara in the chat had asked if there's any prepared resources like checklists or after action reports for preparing EMS handoff.
It's a good question. So I'll try to put in the chat actually a landing page on NETEC's website that has really a whole host of resources for the EMS community. And among those are some examples of patient handoff guides from EMS to, I think, specifically biocontainment units, but it can be adopted. But there's a lot of good resources there. Links to the infectious disease playbook, EMS infectious disease playbook, that's being managed by ASPR and being kept current by them. Blogs that are active, for example, to remind the EMS community about hierarchy of controls for managing a patient that's suspected of having a viral hemorrhagic fever like Ebola-virus disease. Model procedural guidelines for donning and doffing of PPE, modification of an ambulance to protect its environmental surfaces, cleaning of a biohazard spill, et cetera. That guidance is on that website, and a lot more. So I'll make sure that that's in the chat for everyone to see.
Great. Thank you so much. Dr. Maves, we've had several questions about surrounding initiation of care for patients. Let's think about it both from like a level 3 and 4 facility up to one of the regional emerging special pathogens treatment centers. Can you talk a little bit about what facilities should be prepared to do basically from an initial stabilization of a patient, including lab testing?
Yeah, no, it's a great question. I will share a brief anecdote. Back during 2014, 2015, I was still in the military at the time, and I was practicing at the Naval Medical Center in San Diego, and we accepted a patient and transfer from one of our neighboring community military hospitals, who was a young man who had recently traveled back from Sierra Leone, who presented with a febrile illness, and we, after trying to figure out who signed his leave paperwork to get him to Sierra Leone during the Ebola outbreak, we accepted him in transfer, and we coordinated with EMS, much as Dr. Isakov discussed, and got him transported down. We had set aside, we had a kind of hallway in our emergency department where we were able to isolate him safely. And so in terms of laboratory testing, we really did recommend in that case using point of care devices. So we used iStats, we used rapid malaria antigen tests, not as good of a test as other modes of malaria diagnosis. And then we're able to get specimens for confirmation or refutation of the diagnosis. Fortunately, his duration of symptoms and the amount of time he'd been back in North America made it possible for us to rule out Ebola with a single assay. We did that with the State Department of Health in California, and that was very, very rapid. I would say certainly in a person who is a PUI for viral hemorrhagic fever, the bias should be strongly in favor of point of care testing, unless you happen to have a dedicated device, which the great majority of clinical laboratories and the great majority of community hospitals and even university hospitals won't have. There won't be a cytometer. There won't be a Piccolo device, is a commonly used one that is available to be dedicated to that PUI. So I also have a kind of a small bias that I think that a lot of our laboratory testing is extraneous and does not contribute directly to patient care. So there might be some advantages to focusing the mind a little bit in terms of checking to see what you can do. Now, that being said, iStats can get you a lot of good data for that dedicated device. You can generally get common electrolytes, hemoglobin, platelets, creatinine, and the like, and those things can be very helpful. And certainly there's even diagnostic clues that can come off of that, hemoconcentration being a common one. If you have an unusually high hemoglobin or hematocrit detected on an iStat, that is certainly not diagnostic, but certainly suggestive of a number of high consequence pathogens, and that is useful data. Thrombocytopenia, another early and very useful thing, can be detected and identified on this, but the great majority of this is going to be syndromic and supportive care up front. So I think in terms of supportive care, the things that I would be thinking of what you should be able to do other than arranging for confirmation of the diagnosis and, when appropriate, transfer to a level 2 or level 1 center near you, I would plan on being able to provide good, basic, core critical care, right? I would not avoid caring for that patient. I would not minimize the care of that patient. I would not put them on a pathway of less care is good care. I would make sure that they get what they need, meaning if they need fluids, give them fluids. If they need blood, give them blood. If they need hemodynamic support, give them hemodynamic support. If they need oxygen, give them oxygen. There is a question in the chat about intubation, and I think that gets a little bit trickier, but I would say that if you have a team that is prepared and capable of doing that safely, and I think after COVID, that is a relatively common skill set nowadays, I would provide them with that. And what Dr. Dichter was talking about in terms of load leveling, we're talking about an individual patient or a small number of patients. It's a little early for load leveling, but I would argue that the great majority of institutions do not have the longitudinal expertise like Emory and the other level 1 NETEC centers have. And I certainly know that once I have, if I encounter such a patient like this at Wake, we will put them, we have a designated part of our hospital. We're going to be re-drilling that later. And I will put on my PAPR and I will go in and we will provide the best available supportive care. Just a couple of things to think about is malaria is, and the gentleman who I was referring to earlier actually just had malaria. We were all a little grumpy afterwards that a bunch of ID doctors were bored by a malaria case in the end when it turned out to just be malaria. But, very low threshold for malaria diagnostics, a very low threshold, particularly in the patient with organ failure, for empiric malaria therapy, and also a relatively low threshold for empiric antibiotics, appreciating that blood cultures are going to be difficult to obtain and you may just have to deal with it in terms of appropriate, suitably broad spectrum sepsis coverage. Those are the things that I would do. I think that most of the time, as one of my partners says often, medicine is very, very easy. a little bit of a joke, but I think the principles are the same. We have a sick person, we do sick people thing to them, and we take care of sick people, and that's what we should do. There are broader questions, and I saw this in the chat as well about ECMO from Jesse Ross here. I will say that there isn't a lot of recent data on it, but in 2014, 2015, ELSO, the Extracorporeal Life Support Organization, did put out a position statement recommending against ECMO for the critically ill patient with viral hemorrhagic fevers with, well, not all viral hemorrhagic, with Ebola specifically. Of course, there is experience with ECMO for hantavirus. But for patients with Ebola viruses, and that's not because of a sense of not wanting to offer the best available care, but just that the anticoagulation, the invasive nature of an ECMO circuit, and the effects of it make it, based on current data, very unlikely that a patient with Ebola would be likely to benefit from ECMO. It's not a desire to withhold care, but rather a desire to not inflict harm. And I think that is probably a wise statement in the absence of further data. But things like CRRT can be done safely in expert hands.
Absolutely. Yeah. Thank you so much for that. And I think that it just reminds us all that we have the tools and capabilities to at least provide some stabilizing care, and then use our resources to help us kind of escalate that as needed.
Yeah.
I know we're coming to the end of our time together. I think we have time for at least one more question. Dr. Dichter, I wonder if we can talk a little bit about what can be done for planning and preparedness at the regional level. So we've mentioned healthcare coalitions. We have the new National Special Pathogen System of Care, NSPS, that gives us our leveled designations for facilities. How should facilities approach kind of regional level preparedness?
Thanks, Anna. It's a really important question, and one that we don't routinely utilize every day. But there's no substitute for good communication between organizations. And I think during the pandemic, I think that most of us found that having a way to communicate with the other health systems nearby, with the Department of Health often facilitating that, that is probably the most important thing. And it's pretty low tech. Something as simple as a conference call among leadership once a day or however many times a week is necessary really is very important. Having a structured agenda. How many patients are you seeing? How full are your ICUs? Do you have PPE? Things like that to be able to share so that everybody's on the same page. Everyone has the same mental model. But that communication infrastructure leads to everything else. And having a structured agenda of resources that are known that you'll need, that everybody can be able to share across organizations, is really crucial. Again, it's also if you will, a clearinghouse for ideas and thoughts. People are all going to approach things differently, and usually end up with best practices by sharing those across organizations. Again, load balancing, as we've talked about on the call already, is really important. Early load balancing is what I think we would all counsel, to be able to really make sure that everybody's able to provide the care they need to, as well as the care needed by the special population. But again, setting up a communication infrastructure is the first thing. And my guess is, if you already have such an infrastructure locally or regionally or at a state level put together, to utilize that. And my guess is, if the pandemic is not so distant that we don't have memories of and knowledge of our friends across the city or the region. But again, I emphasize having that communication infrastructure in place and ready to go. Having a conference call before the World Cup starts would be an easy thing to do for an hour, just to kind of get to know each other, make sure you have each other's phone numbers, make sure that there's a way to pull a call together quickly if you need to. Those are the kinds of priorities that I would see for any local region, city, or state.
Thank you so much. I think that liaising with each other and having those conversations is always the best place to start. I know we only have a couple minutes left. I want to give our panelists just an opportunity to share one final pearl of wisdom with our attendees before we move into some of our resources slides. Maybe I'll start with Dr. Isakov to put you on the spot.
Yeah, sure. Well, I'm gonna reiterate my identify, isolate, and inform paradigm. I think it's a great way for any frontline personnel and frontline of systems of care, whether it's EMS, ambulatory care, emergency departments, to think about identifying somebody who has an infectious disease or communicable disease of concern, help to identify that individual. It helps us think about how to protect ourselves from exposure to potentially infectious bodily fluids by isolating the patient, applying an appropriate PPE ensemble, implementing a hierarchy of controls. And then the informed piece is critically important too, and it can help frontline personnel, get answers to questions that they don't have the answers to. Should I be more concerned about this individual harboring an HCID? And in many cases, the state public health department, typically through a toll-free number, is a great resource. And depending on how your resource, maybe infectious disease and IPC consultants in your facility would be a great resource.
Great. Dr. Maves?
My cat just decided to join me here. This is Gunther. Say hello. I'm going to be lazy and springboard off of something that Dr. Dichter said, which is talking about healthcare coalitions. I think during the pandemic, it did a great deal of good in the places it did it well. The state of Minnesota, a standout. Also, the state of Washington. I think we did a pretty good job of it in Southern California. I think other regions did not. And I think that some of the challenges are the competition between large corporate health systems kind of inhibits our ability to do these degrees of coordination. And I think that we need to find a better way to do that in the future. So I guess I'll call that an area for future improvement. Thanks.
Thank you. And thank you, Gunther. Dr. Dichter, take us home.
Just again, it dovetails on what my colleagues have said and what I said earlier. Communication early and often to those who can help you. That's often the most important thing when you recognize at the point of care that you're something that you're not used to dealing with. As an organization, use your local departments of health, use your colleagues, use your sister organizations in the system, reach out to others, always communication. And I'm going to also say something else about NETEC, if I may, Anna. NETEC is the National Emerging Pathogens Teaching and Education Center. For those who are not as familiar with NETEC and their website, there is a remarkable number of different webinars and education things that are of great value when it comes to unusual pathogens. And it's just a wonderful website. It's free. Their webinars, their information, it's just a wonderful clearinghouse of information. So I encourage people to look at it and think about it in preparation, before we get all the fun started a month from now or thereabouts.
Thank you so much. Thank you to our panelists and to our participants and all your amazing questions and conversation. We wanted to call your attention to just a couple resources. We'll be sharing these slides in the NETEC resource library so that you have access to some of the resources that we've talked about today. And then also feel free to use the NETEC resource repository for drilling. I saw a lot of questions about drilling, other checklists, other things for facility level preparedness. Remember, please, that we have a lot of support services, all free and available to you all. If you are interested in technical assistance or any other help, feel free to submit a request online or email info@netec.org. Also, if you have questions from today's webinar that you just didn't get answered, feel free to email us at info@netec.org. And so with that, I'd like to say thank you to everybody for your participation, and please be safe out there.